Hi everyone! Welcome back to Izzy Medicine, where we make complex medical topics just a little bit more manageable. Today we're tackling Cushing's disease and Cushing's syndrome. So, grab your notes and let's break down cortisol like pros. So before we learn about the disease processes, it's important to understand how cortisol normally works in the body. So let us break it down. The hypothalamus, which is in the brain, you can think of it as the team leader. It releases CRH, or corticotropin releasing hormone. CRH then sends a signal to the pituitary, and it signals the pituitary gland to release ACTH, or adrenocorticotropic hormone. ACTH then travels down to the adrenal glands through the bloodstream, and it tells the adrenal glands to produce cortisol, the stress hormone we all know and love, in moderation, of course. Cortisol then does its job. When it does its job, it enables the body to handle stress, regulate metabolism, it helps with the immune response, it helps with gluconeogenesis or glucose production, and various other functions. When there's enough cortisol circulating in the body, either bound or unbound, it sends basically a mission accomplished signal back up the chain to the brain, and it tells the hypothalamus and the pituitary gland to dial it down. And at that point, the pituitary gland and the hypothalamus can dial down the amount of CRH and ACTH that they make. This is a negative feedback loop, and this negative feedback loop is what keeps everything in balance. So what happens in Cushing's? Basically, the balance goes out the window. Let's discuss the conditions that can cause elevated cortisol. There are a few. We have what's called ACTH-dependent Cushing syndromes and ACTH-independent Cushing syndromes. Let's review ACTH-dependent Cushing syndromes. Under that umbrella, we have Cushing's disease. Basically, what Cushing's disease is where our pituitary gland develops a tumor known as a pituitary adenoma. Oftentimes it's benign, sometimes there are malignant tumors. This tumor starts producing ACTH like there's no off switch. And when that ACTH gets released through the bloodstream and, as expected, travels to the adrenal glands, it makes the adrenal glands continuously pump out cortisol. And when that cortisol travels back to the pituitary gland and tells it, hey, we need to keep everything in balance, please dial back the ACTH, the pituitary gland doesn't do that because it has a tumor and is in overdrive. So essentially our feedback loop is broken, and this leads to persistently high cortisol levels. So in Cushing's disease, we have elevated ACTH levels and elevated cortisol levels. Another scenario that is falling under ACTH-dependent Cushing syndrome is an ectopic ACTH syndrome. So basically, ectopic is outside of, and here a tumor elsewhere in the body, oftentimes in the lungs, through small cell lung cancer, starts producing ACTH. And this extra ACTH from a different tumor, ectopically, drives the adrenal glands to overproduce cortisol, just like in Cushing's disease, but the source is outside of the pituitary gland. So we have the same scenario. We have elevated ACTH and elevated cortisol. Then what we have is we have our ACTH independent Cushing's syndrome. And what that means is that we have cortisol production that is independent of how much ACTH is present. Specifically, one such situation is where the adrenal glands take matters into their own hands. Usually the cause is an adrenal tumor. So we have a tumor in our adrenal glands, and the tumor starts producing cortisol without any input from the pituitary gland, without ACTH. And what happens there is when that cortisol is elevated, it sends a signal back to the pituitary to try to get back to normal balance. The pituitary gland actually listens this time because in this particular scenario, it's healthy and it reduces ACTH. Unfortunately, that reduction in ACTH doesn't affect the adrenal gland because the adrenal gland has a tumor in overdrive. So what we're going to see is we're going to see elevated cortisol levels and low ACTH levels. Another condition is if someone's just been on long-term corticosteroid therapy. That can also lead to Cushing's syndrome because it mimics high cortisol levels in the body, because therapy steroids specifically are very similar in function to cortisol. So if you have a patient that maybe has autoimmune conditions such as lupus, maybe arthritis, maybe an organ transplant recipient, or various other conditions that require long-term corticosteroid therapy, they may develop Cushing's syndrome over prolonged use. So now that we know what normal is and what the abnormal conditions are that can cause this, what does cortisol overload look like in a patient? If you have a patient that comes in, how are you going to recognize them? Let's review a little bit of the physiological and physical changes that a patient may have. What cortisol does, one of the functions, is that it increases lipolysis or fat breakdown. Lipolysis increases more significantly in the limbs, in the arms and the legs. When that fat breaks down in the arms and the legs, it also gets redistributed to the central portion of a person's body. What we see oftentimes is that we have fat accumulation in the trunk, and we have fat accumulation in the face, which causes us to have what we call a moon face. The face looks very rounded and moon-like. And we also get those fat deposits on the upper back between the shoulder blades, which is called a buffalo hump. And at the same time, cortisol breaks down the fat and the muscle tissue in the arms and the legs, leading to what we call noodle arms and legs, thinning extremities. Another thing that you might see is skin that becomes thin and fragile, that bruises easily, and also gets purple stretch marks called striae. So this happens because cortisol breaks down collagen, and this is the protein that gives your skin its strength and elasticity. On exam, or just when you're observing your patient, you might notice that their skin is friable, they bruise more easily, and they have those stretch marks on areas that have a little bit more fat on them, specifically on the abdomen. What else do we see? So besides the appearance of such a patient, you might also notice that a patient is presenting with more frequent infections, maybe more frequent upper respiratory infections or more frequent sinus infections. This happens because cortisol dampens the immune system. It decreases the activity of T cells and macrophages, and it makes the body more susceptible to infection. You also might notice that your patient complains of wounds healing slower. The reason why there's slower wound healing is because cortisol reduces inflammation, and the inflammatory cascade is responsible for healing. And without that inflammatory cascade, wounds may take longer to heal. Another thing that we might notice when we see a patient with Cushing's, maybe on the first visit, maybe on subsequent visits, is that we may notice on exam that their blood pressure is elevated. So cortisol increases blood pressure, and the reason it does that is it sensitizes blood vessels to catecholamines like adrenaline, and also promotes sodium retention. So the combination of sodium retention, which increases blood volume, and narrower blood vessels increases the pressure gradient within the vessels, and that leads to higher blood pressure. We also might notice that our patient has elevated blood sugars on blood work that we may order. So the pathophysiology behind this is that cortisol raises blood sugar by increasing insulin resistance, and also it promotes gluconeogenesis, which is glucose production in the liver. And over time, an elevated glucose production as well as resistance to insulin, which, as we know, reduces glucose, can lead to diabetes. So that's another cardiovascular endocrinological effect that we may notice in our patients. Additionally, we have to be concerned with cortisol decreasing bone formation and increasing bone resorption. And oftentimes, patients with Cushing's have weaker bones and are at a higher risk for fracture. So now that we see this patient and we suspect, perhaps based on the signs and symptoms, that this patient has Cushing's, how do we diagnose it? It's kind of like detective work where you do tests and continue to gather the clues from all the tests. So we usually start with a 24-hour urine-free cortisol. This test measures the amount of cortisone produced over a day and spilled through the urine. Essentially, you give your patient a prescription. They go to the lab and they get this huge plastic jug that they pee in for 24 hours. If the cortisol is elevated in that 24-hour urine test, that's our first clue that we need to proceed with further evaluation. Another test that we can do is what's called a low-dose dexamethasone test, which we give our patient 1 milligram of dexamethasone, which is a synthetic steroid, and we see if it can suppress cortisol production. If it doesn't, and there's still cortisol in production, that points us towards Cushing's again. After we see that there's elevated cortisol, what do we do next? So essentially we have to delineate the source. And we do this by measuring ACTH. Low ACTH suggests that the adrenal glands are the source of the problem, because as we know, when the adrenal glands are in overdrive, they produce high amounts of cortisol, and there's low ACTH. If there's high ACTH, it indicates that it's either our pituitary gland that is in overdrive producing too much ACTH, or we have that ectopic paraneoplastic ACTH producing tumor, such as a small cell lung cancer or perhaps a different tumor. If we see low ACTH, we can then proceed with getting a CT scan of the adrenal glands to confirm and look for that adrenal tumor. If there's high ACTH, we proceed with the next test. And the next test is a high-dose dexamethasone suppression test. In this test, we give 8 milligrams of dexamethasone, and this helps to differentiate between pituitary or our ectopic tumor. If cortisol levels decrease, it suggests a pituitary source, because high enough levels of steroid given to a patient should suppress the pituitary from producing ACTH, and in turn from cortisol being elevated. In an ectopic tumor, the ectopic tumors do not respond to any high level of steroid and continue to be in overdrive, releasing ACTH and releasing cortisol. So we'll see high levels of cortisol remaining. This is another step where we can approach this through imaging. So we can image our pituitary gland with an MRI, or do a CT scan of the chest if we're looking for small cell lung cancer, or other imaging modalities if we're looking for an ectopic tumor to help us possibly locate the tumor. So now that we know a little bit how to get to a diagnosis, what do we do once we've nailed down the diagnosis? How do we treat it? Of course, the treatment, as with any condition, depends on the cause. So let's break it down. If it's Cushing's disease and we're dealing with a pituitary tumor, pituitary adenoma, then the primary treatment is surgical removal. And it's usually done through a procedure called a transsphenoidal resection, where a surgery is done through the nose and the tumor is removed. If surgery isn't an option or isn't fully effective, then we prescribe for ketoconazole, which is, interestingly enough, as we know, an antifungal, and it can be used to inhibit cortisol production. If the cause is an adrenal tumor, and that's the culprit, the treatment is typically surgically removing the tumor. If surgery isn't possible, other medications can be used to control the cortisol levels. If it's an ectopic ACTH syndrome with an ectopic tumor, and we've been able to locate the tumor and it's operable, surgical removal is the preferable treatment. And if surgery isn't feasible or we weren't able to isolate the tumor, similar to other cases, medications like ketoconazole may be used to manage cortisol levels. And last but not least, if our Cushing's syndrome is due to long-term steroid use, the treatment involves gradually reducing the steroid dosage, and it has to be done very carefully, of course, because we don't want to cause issues with the adrenal gland not functioning and the patient being completely devoid of steroids. So that's a wrap on Cushing's disease and Cushing's syndrome. I hope that this was helpful. If you found it helpful, don't forget to like, subscribe, and hit the notification bell. Thank you for watching. Leave a comment if you have any questions, and I'll see you in the next video.